Okay, നമുക്ക് ക്ലാസ് എന്തായാലും തുടങ്ങാം ബിക്കോസ് ദിസ് ഈസ് റെക്കോർഡഡ്. അപ്പോൾ കുട്ടികൾ ജോയിൻ ചെയ്തോളും, പ്രശ്നമില്ല. നമുക്ക് സമയത്തിന് തന്നെ നമുക്ക് തുടങ്ങാം. ഐ നോ ക്ലാസ്സസ് മീൻസ് ഇനിയിപ്പം സമയം കുറവായതുകൊണ്ട് മോസ്റ്റ് ഓഫ് സ്റ്റുഡൻസ് അവർ പഠിക്കുന്നതിൽ കൂടുതൽ ശ്രദ്ധിക്കുന്നു. അപ്പോൾ അതുകൊണ്ട് ടെൻഷനാണ്. പലപ്പോഴും നമുക്ക് ലൈവ് കയറാനായിട്ട് ഉള്ള ഒരു മാനസികാവസ്ഥ കാണത്തില്ല. ഐ അണ്ടർസ്റ്റാൻഡ്. ബട്ട് സ്റ്റിൽ നമുക്ക് ലൈവ് കയറുമ്പോൾ ഉള്ള കാര്യം എന്ന് വെച്ചാൽ കുറേ കാര്യങ്ങൾ നമുക്ക് ഓർമ്മയിൽ നിൽക്കും. ലാസ്റ്റ് നമുക്കിതൊന്നും പെട്ടെന്ന് അങ്ങനെ പഠിക്കാൻ പറ്റില്ല. എസ്പെഷ്യലി ഈ ഡെർമറ്റോളജി എന്ന് പറയുമ്പോൾ നമുക്ക് എല്ലാവർക്കും അറിയാം, ഡെർമറ്റോളജിക്കും മെഡിസിൻ്റെ കൂടെ നമുക്ക് ഉള്ളതാണ്. പല ഹിൻസും ഇതിനകത്തുനിന്ന് തന്നെ നമുക്ക് കിട്ടും. ക്വസ്റ്റ്യൻസ് എല്ലാം കണക്റ്റഡ് ആയിട്ടായിരിക്കുള്ള ക്വസ്റ്റ്യൻസ് ആണ് കൂടുതലും ചോദിക്കുന്നത്. ക്ലിനിക്കലി ഓറിയന്റഡ് ആണ് കുറേ നാളായിട്ട് ചോദിക്കുന്നത്. അപ്പോൾ അങ്ങനെ വരുമ്പോൾ നിങ്ങൾക്കത് വളരെ യൂസ്ഫുൾ ആയിരിക്കും. അതുപോലെ തന്നെ പല പല എക്സാംസ്, ഒരു എക്സാം മാത്രമല്ല, പല പല എക്സാംസിനും വളരെ യൂസ്ഫുൾ ആയിട്ടുള്ള കുറേ ടിപ്സാണ് സാറിൻ്റെ ക്ലാസ്സസിൽ നിന്ന് എപ്പോഴും കിട്ടുന്നത്. കഴിഞ്ഞ പ്രാവശ്യവും അത് വളരെ യൂസ്ഫുൾ ആയിരുന്നു. അപ്പോൾ അതുകൊണ്ട് ഇത്രയും വലിയൊരു ഏരിയ മറ്റ് സോർട്ട് ആഫ്റ്റർ സ്പെഷ്യാലിറ്റി നമുക്ക് ഒരു ക്ലാസ് കൊണ്ടൊന്നും നമുക്ക് ഒരിക്കലും എല്ലാം ഒന്നും പറ്റത്തില്ല. അത് മാത്രമല്ല ഇനിയിപ്പോൾ അതെല്ലാം ഇരുന്ന് പഠിക്കാനും സമയമില്ല. സോ ബെറ്റർ യു മേക്ക് യൂസ് ഓഫ് ദിസ് opportunity, and we have brought an esteemed faculty who is very much interested in taking classes. But സാറിന് സമയം കുറവുണ്ടെങ്കിലും സാറിന് സമ്മതിച്ച് നമുക്ക് ക്ലാസ് എടുക്കാൻ വരുന്നുണ്ട്. ആൻഡ് വേറെ സോ മച്ച് താങ്ക്ഫുൾ ടു സർ. അപ്പോൾ ഫിറോസ് കണിയൻ സാറാണ് വന്നിരിക്കുന്നത്. ആൻഡ് ഓവർ ടു യു സർ.
Okay. Thank you, Dr. Sapna. And once again, I think the students should also appreciate Dr. Sapna and her team also. So, I think it's a huge effort. So, I think you deserve a round of applause also. Okay. So let's start today. Having joined you can join on.
കുഴപ്പമില്ല സാർ, അതെ.
No problem. Done. Okay, so would be great if we can put in answers in the chat also. We can try to make it as interactive as possible. Okay. So dermatology, when you think of it, the treatment part is, in one way, it's very simple. Extreme simple, it's not like if it's wet, keep it dry. If it's dry, keep it wet. But still, basic ideas are there, then it's relatively easy to understand the treatment of most conditions in dermatology. Okay. And when we talk of conditions itself, the problem with dermatology is that there are a huge variety of conditions. Skin being the largest organ, any area can be affected, and you can have diseases of the hair, nail, skin, mucosa, all as part of dermatology. I think these are all very simple cases. Any comments on the diagnosis? So first case, anybody? Very common condition. Put it on the chat.
Acne vulgaris, sir.
Normal acne, na? So second one, the clue to the diagnosis is this sharp demarcation. Bilateral, almost symmetrical, sharp demarcation. What you're seeing is some redness, a bit of blister formation, some areas. Patient history would be that he or she has got itching on that area. So whenever you see a sharp demarcation, always think of what we call as contact dermatitis, which is one form of eczema. Okay. This is psoriasis, classical erythematous scaly plaques on the extensor surfaces. That's clear, but then these are viral warts. You can see the small papules. Viral warts, and again, to remember it easily, remember that the scientific name of viral wart is Verruca vulgaris. And why Verruca vulgaris? Because the word vulgaris denotes a lot of conditions which are common. Word vulgaris means common, basically, in Latin. So the commonest type of psoriasis is psoriasis vulgaris. Commonest type of acne is acne vulgaris. Commonest type of wart is the common wart. So then Verruca vulgaris. And why Verruca? Because the surface is rough. So when we cherry papules, cherry raised lesions with a rough surface, we think of Verruca vulgaris or common wart. This should be easy. Then what is the diagnosis over here? Depigmented white, chalk white lesions.
Vitiligo.
It could be vitiligo. Swapnina answer parana or
Allah, sir.
who is this?
Sir, Varun Karaju.
Okay, good. So yeah, Ramya also in the chat. Classical vitiligo. What about this condition? ഇവിടെ എന്ത് കാണുന്നു? You have vitiligo over here. ഇവിടെ കാണുന്ന എന്തൊക്കെയാണ്? Not the diagnosis, but the lesions itself. So you've got blisters over there. Good. So the large blisters are what we call as bulle. And ഇവിടെ you're seeing a bit of in the area which is kind of eroded. There's a bit of crusting. So sound പ്രശ്നമാണോ?
ഇല്ല, സൗണ്ട് കേൾക്കുന്നുണ്ട് സാർ, കേൾക്കുന്നുണ്ട്.
അല്ല പിള്ളേര് ചാറ്റില്
സൗണ്ട് അപ്പൊ സാറ്
കുറവാണ്.
എന്തെങ്കിലും സാറ് എനിക്ക് തോന്നുന്നു വീഡിയോ ചിലപ്പം ഓഫ് ആയി കഴിഞ്ഞാൽ കുറച്ചുകൂടി
ഞാൻ
സൗണ്ട്
നോക്കട്ടെ,
ക്ലാരിറ്റി
ജസ്റ്റ്
വരും.
ഒന്ന് സൗണ്ട്.
പക്ഷെ കേൾക്കാൻ പറ്റുന്നുണ്ട്. ഈ മൈക്കിന്റെ എന്തെങ്കിലും അതുകൊണ്ടാണോ എന്നറിയില്ല.
മാക്സിമം ആക്കി നോക്കട്ടെ. ഇപ്പൊ ബെറ്റർ ആണോ?
ഇപ്പം ബെറ്റർ ആണ്.
ഓക്കെ, എന്തെങ്കിലും ഉണ്ടെങ്കിൽ ജസ്റ്റ് പുട്ട് ഇൻ എ നോട്ട് മറ്റേ ചാറ്റില്. സോ ഇവിടെ കാണുന്നത് ഓക്കെ, റൈറ്റ്. What you're seeing over there is blisters, bulle, erosions, bit of crusting and all those things. നമ്മൾ ജനറലി ഇങ്ങനെ വലിയ ബ്ലിസ്റ്റേഴ്സ് കാണുമ്പോൾ യു ഓൾവേസ് തിങ്ക് ഓഫ് വാട്ട് ഇസ് നോൺ എസ് വെസിക്കുലോ ബുള്ളസ് ഡിസോർഡേഴ്സ്. അപ്പോൾ അതിൽ there's a whole group of conditions and we'll try to differentiate how okay അത് somebody else is saying that sound കേൾക്കുന്നില്ല. ഒരു മിനിറ്റ്, ജസ്റ്റ് ഒന്ന് ഹെഡ്ഫോൺ മാറ്റിയിട്ടൊന്ന് നോക്കട്ടെ. സൗണ്ട് ബെറ്റർ ആണോ? ഓർ സെയിം സിറ്റുവേഷൻ? കേൾക്കുന്നുണ്ടോ? ഓക്കെ. Okay, so let me know anytime you feel that it's not clear, just let me know. Okay, right. So, like we said, ഇങ്ങനെ കാണുമ്പോൾ you always think of what is known as primary autoimmune bullous disorders. എന്താണ് ഈ primary autoimmune bullous disorders വരുന്ന conditions? 3 common conditions. So you have something called pemphigus. You have bullous pemphigoid. And you have dermatitis herpetiformis. There are others also, but ഈ 3 items ആണ് നിങ്ങളുടെ എക്സാമിന് ബേസിക്കലി വേണ്ടത്. So ഇത് 3ഉം and the differentiation പറഞ്ഞാൽ you can basically cover any question related to that aspect. And finally, ഇതെന്താണ് last one? It is basal cell carcinoma. So you can see that ഒരു മറ്റേ rodent ulcer മാതിരി ഒരു central ulceration with the surrounding raised crater-like edge. So just to show you that, dermatology, you can get a huge variety of cases ranging from mild conditions like acne to things like carcinomas. Okay. And the other significance of dermatology is this aspect. Then the diagnosis.
SLE rash on.
Good. So whenever you see female patient, facial rash, arthritis, first thing which ideally should come into your mind is malar rash of SLA. Okay. So, which is why the other significance of dermatology is that it can be a marker for systemic disease, and or area you might get a few questions, which also we'll try to cover over here. Okay, right. Then
Hansen's disease.
very good. So you can see that there's a combination of things happening over here. The most prominent is this hyperpigmented lesion with a saucer-like edge over there. And if you ask or if you examine further, you'll find that there's a sensory loss on that area.
Leprosy.
This is leprosy. So this is classical leprosy. And just to show you that leprosy can also have a huge variation from single patch tuberculoid leprosy to severe deformity, as you would get in lepromatous leprosy. Okay. So, and although you may not get too many questions from this area, the other aspect of dermatology, fortunately or unfortunately, is the cosmetic dermatology aspect. Hair transplants, then what is happening over here, the middle image. This is before, this is after.
So wrinkling treatment for Botox. Botox is given.
Good. So which muscle is being paralyzed over here? So Botox is something which we give for what we call as dynamic wrinkles. Wrinkles which are primarily because of the contraction of muscles. Okay. And one of the commonest muscles which we treat is the occipitofrontalis. Okay. So അത് പാരലൈസ് ചെയ്യുമ്പോൾ നമ്മൾ ഈ ഫോർഹെഡ് ലൈൻസ് ഫ്രൗണ്ട് ലൈൻസ് എല്ലാം കുറയും എന്നുള്ളതാണ് എൻ്റെ ഒരു കോൺസെപ്റ്റ്. And this, of course, is lasers. Any idea what this is called? This will not come for the exam anyway. I'm just asking you. ഒരു കറുത്ത സൊല്യൂഷൻ ഇട്ടിട്ട് ഒരു പിഗ്മെന്റ് ലേസർ വെച്ച് പൊട്ടിച്ചാളെന്ന് പരിപാടി എന്താ? Good, Ramya. That's called a carbon peel. Okay, facial carbon peel. That's done using something called a Q-switched Nd:YAG laser. Okay. So this is one image I always keep just to show you that, how therapy in dermatology has developed. So this was something which maybe a few years ago was virtually untreatable. Okay. But now we have options for such a condition. What do you think this condition is called? The skin lesions look like very, very thick hyperkeratotic lesions, almost like a tree's branch, which is why this person is called a tree man. Any idea what the condition is? This is a rare condition. This is called epidermodysplasia verruciformis. And, it's related to the warts which we discussed earlier. It's almost like a much severe kind of thing. Okay. And this is the post-treatment. So he was treated with a combination of things, including lasers, but more importantly, systemic retinoids. Okay. Just to show you that some things which earlier we found difficult to treat, or virtually there was no treatment, are now treatable because of the advance in dermatological therapy. Okay, now in the NEET exam, if you look at the previous questions, there are around 18 areas from where questions normally come. And our 18 areas, there are some highly yield areas which we will focus on this time. And there are some other highly yield areas which, if you have another session, we'll try to cover it over there. So acne, vitiligo, papilloscomus disorders, lichen planus, dermatitis, vesicular bullous. This is what we'll try to finish in this session. High yield in the parayam കാരണം if you see, quite a few questions come from these areas. Okay. So നമ്മൾ വേറെ ഒന്നുമില്ലെങ്കിൽ നമ്മൾ ചെറിയ MCQ ഗൈഡ്സിൽ ഈ ഏരിയാസിലുള്ള ക്വസ്റ്റ്യൻസ് സോൾവ് ചെയ്ത് പോയാൽ തന്നെ you should be able to cover dermatology. Dermatology, content-wise, it's not that huge. So your areas focus then you'll be able to score well over there. Now, quickly, before going into the MCQs itself, it might be easier for you to understand the concepts if you can, quickly remember what the description in dermatology is. Description, there are certain terms which we use to describe dermatological lesions. And the idea of this was that, when a person describes what he or she is seeing to somebody else, the other person should be able to understand what the first person is talking about without seeing the patient. So description should be as detailed as possible, plus also it should be standardized. So there are standardized terms which we use over there. The commonest term which we use is this thing. Then in the any flat lesion is called what? So what you're seeing over here is a lesion which is flat, which is not raised. Flat, it could be a change in color or it could be a change in texture as compared to the surrounding skin. What do you call a flat lesion scientifically? Good. It used to be called a patch, but now we prefer using the word macule irrespective of size. Rather, Panda we used to call it macule and patch, smaller macule, larger patch, but now any flat lesion is called a macule and we just give the size. Okay. So lesion is a macule, flat lesion, and diagnosis is vitiligo. Then there so you have these small bumps over here, raised, solid.
Papule.
It's called a papule. Good. So, quickly, the simple way of putting it would be a flat lesion. We call it a macule, right? If it is raised, you can have a small raised lesion like this. You can have a lesion which is like this, which means it is spread over a larger area. Or you can have a lesion like this. We're talking about solid lesions. This is a papule, like you see in the image over here. Okay. What about this one? It's raised. It's solid, but it's spread out over a larger area. So it's not one single bump. It's like, it's covering a larger area. So what is that called? Like you get in, say, psoriasis, for example. Again with P, starting with P. PL. Good. Called a plaque. And what about the third one? Third one, it's not only raised above the skin, but there's something below the skin. So it's like, a ball. You can feel it below the skin, although you may not be able to see it. So that is called a good. That's called a nodule. Okay. So papule, plaque, nodule. These are the three common solid lesions. The flat lesion is called a macule. Idhe mari, you can have a small fluid-filled lesion. We can have a do that again. Small fluid-filled lesion. We can have a large fluid-filled lesion, or you can have a lesion which shows visible pus. So, what are these things called? Small fluid-filled lesion, typically like you get in chickenpox. It's called a vesicle. Good. And a large one is called a small one is a vesicle. The same thing when it is bigger, like papule and plaque, is called a bulla. Good. And if it contains visible pus, which means the pus is very superficial visible, not deep like an abscess, we call it a pustule. Good. Okay. So papule, plaque, nodule, vesicle, bulla, pustule. So these are the commonest things which probably will come as part of the description. So this was a papule. This is a plaque like you get in psoriasis. Nodule, soft nodules like you get in. Just share the screen again. Like you get in neurofibromatosis. Vesicles like you get in chickenpox. Bulle like you get in bullous pemphigoid. And bulle skin you have this area of raw skin below this. Okay. That is called an erosion. Okay. So bulle, when the roof goes off, what is left behind is what is called a erosion. Then the visible pus. What lesion and any diagnosis that you can think of? Pustular, good. And imagine that this patient had a history of scaly erythematous skin lesions before, and they turned into this. What would your possible diagnosis be? One possibility, good. Any other possibility? So this is an example of what is known as pustular psoriasis. Good. Okay, so normally psoriasis, now what comes to your mind is a red scaly plaque, but there is a variant in which you can get pustules instead of the scaly plaque. That's called pustular psoriasis. Okay. But Varunka, you're right. You can also get this kind of picture sometimes in SSS. Okay. Okay. Any redness is called erythema. Could be due to localized vasodilatation, could be due to vascular congestion of any kind, could be due to inflammation of any kind, but any redness of this kind is labeled as erythema. This white material you get on the surface of some conditions, especially things like psoriasis, is called scales. Okay, and the process is called exfoliation. So scales, exfoliation. This is what we talked about earlier. ഒരു ബുള്ള ഉണ്ടായിരുന്നു ആ ബുള്ളയുടെ റൂഫ് പോയിട്ടുണ്ട്. What is left behind is called what we just mentioned before. The primary lesion was a bulla, and അതിന്റെ roof പൊട്ടി കഴിഞ്ഞാൽ that raw area left behind is very good. It's called an erosion. Okay. And what is this? What is your diagnosis and what is the lesion itself? Very common in children, especially on the face. Color is typically described as honey colored. So sometimes, when you have inflammation in the skin, you can have fluid coming out, which is known as oozing. Our fluid dry, it's called crusting. Okay, so that's what you see over here. And this kind of yellowish, slightly honey-colored crusting is typical of what we call as very good, normal, impetigo. Okay, which is especially common in children. So crust, impetigo. And this should be easier. So diagnosis is acne. And what are these lesions called? Common languagely, what do you call it? You call it blackheads in common language, good. And then scientifically, you call it comedones. So you've got open comedones and closed comedones. Open comedones are black in color, while the closed comedones tend to remain white in color. Okay, good. And any decrease or absence of hair from an area which is normally hairy is labeled as alopecia. Okay. And there are different kinds of alopecia. You have patchy alopecia, like you get an alopecia areata. You can get diffuse alopecia, like you can get in things like telogen effluvium, pattern hair loss, and so on. So alopecia. Okay. Now this is one area where a couple of questions have been asked. So first look, it looks red. So erythema എന്ന് പറയാൻ വേണമെങ്കിൽ, പക്ഷേ it looks a little more red than just erythema. So what would you think of? നമ്മൾ ഇത്രയും ഒരു റെഡ് ലീഷൻസ് കാണുമ്പോൾ. So if you think of dengue, what are the lesions called? Could be due to dengue, it could be due to, okay, vasculitis is one possibility, but still very good. So these are purpura. Okay, purpura can be different types. It can be palpable purpura, like you can get in vasculitis. It could be simple purpura, like you get in thrombocytopenia associated with dengue and so on. So purpura is basically redness of the skin due to extravasation of blood. Okay. And how would you differentiate this from erythema? So ഇത് കണ്ടാലിപ്പോൾ നമ്മൾ വെറും erythema purpura ആണെന്ന് എങ്ങനെ തിരിച്ചറിയും? Very good. And that's called a diascopy. So what you do is that we take a glass slide and we press these lesions. അത് blanch ചെയ്യുന്നുണ്ട്. Basically, if the lesions disappear, then that indicates that it is simple erythema. While if it is purpura, it does not disappear. Okay, that is called diascopy. It's done using glass slide. It's also called a glass slide test. Right. Then so as you grow old, your skin support, dermal tissue, all those goes down. So the skin becomes wrinkled. And that change is called, starting with A, AT, ATR. Good. Atrophy. And other the significance is that in terms of your exam thing, one thing you need to remember is one of the very common medicines which we use in dermatology topically can cause this as a side effect. So which medicine causes skin atrophy? And which is why you need to be a bit careful with that medicine, especially when you're using it on areas like the face, flexures, and so on. Good. Topical steroids. Okay, so why we are always advising that you need to be careful with topical steroids is because if you use potent steroids for a long time, especially on areas like the face, sensitive areas and all, it can lead to this problem called atrophy. So you can get increased skin markings, the skin becoming thin, increased vasculature. And once it reaches a certain point, it's irreversible. So you can't go back to your normal skin. That's why you need to be careful about which steroid to use where and how long. Okay, so steroid atrophy. Right. So now let's start off with the questions itself. Okay. And what we'll try to do is that we'll go with the questions, but we'll try to discuss a bit of theory associated with this. So first question, simple question. Direct question. You have questions which are associated with images also now. So very good. So simple question. Herpes labialis caused by which virus? HSV1 or 2 or both? So good. So herpes labialis is typically characterized by a grouped kind of vesicles. Okay. കുറേ ഒരുമിച്ച് കുറേ വെസിക്കിൾസിന് കൂടി നിൽക്കുന്ന മാതിരിയാണ്. Typical site is the lips, and in general, the concept is that the genital lesions are caused by HSV2 and the oral lesions are caused by HSV1, but maybe there can be a bit of cross happening over there. Okay, so HSV1 usually, herpes labialis. Okay. Now, this is one example of where the distribution of skin lesions is also important. So again, diagnosis should be quite clear. And then diagnosis, shingles, or scientifically called herpes zoster. Good. And herpes zoster is caused by the same virus which causes chickenpox, which is the varicella zoster virus. Okay. So the clue to the diagnosis is the distribution. So single dermatome. The primary lesions are the same as in herpes labialis, vesicles, but tends to be a bit more of erythema, and more importantly, the nerves can be involved. So the patient complains of severe pain. And the dermatomal distribution is what gives you a clue to the diagnosis, caused by varicella zoster virus. What would your drug of choice be in this case? If the patient comes in sufficiently early time, what drug would you give? Oh, so I'm assuming acyclovir, no? Okay, yeah. So acyclovir is the drug of choice. Now, of course, we prefer giving valacyclovir because it's more easy to give. The number of doses are less. Okay. This is another example of where the distribution or the pattern can give you a diagnosis. Okay. So here, a pattern in the paraya. It looks like a ring. Good. So diagnosis is quite simple. Tinea corporis. Good. But what do you call this pattern? It's like a ring-like lesion. Peripheral activity in the center is clear. Very good, Libin. So it's called annular. Okay, so there are a lot of annular lesions, but then for your exam, remember that the most common annular lesion that you're going to get is tinea corporis. Okay. Tinea corporis is caused by which fungus, which group of fungus? So so you'd have heard of three groups over there. So epidermophyton, microsporum, and trichophyton. നമ്മൾ ഈ മൂന്ന് ഐറ്റംസ് എവിടെ ഇൻഫെക്ഷൻ ആക്കിയാലും ഇറ്റ് ഇസ് ലേബിൾഡ് ആസ് ടീനിയ. ഓക്കെ, അതിന്റെ സെക്കൻഡ് പാർട്ട് ഇസ് ദ സൈറ്റ്. സോ ഇറ്റ്സ് ഓൺ ദ ബോഡി, ടീനിയ കോർപ്പോറസ് ആയി. ഓൺ ദ സ്കാൽപ്പ്, വാട്ട് ഡു യു കോൾ ഇറ്റ്? ടീനിയ കോമൺ ആയി. ദ സെക്കൻഡ് പാർട്ട് ഇസ് ദ സൈറ്റ്. സോ സ്കാൽപ്പില് ഗുഡ് ക്യാപിറ്റസ്, ഗ്രോയിൻസില് good, groins is crurus, feet would be pedis, and hand would be manum or manus. Okay. Just think of it like, you for the feet, you do a pedicure. For the hand, you do a manicure, which is why pedis, manum. Okay. But basically, it is all dermatophytosis. Our group together is dermatophytosis, and any site, we call it tinea. Okay. Most important thing is the annular appearance. Okay. Now, whenever you study, little suggestion is that, try to correlate with your basics so that, your anatomy, biochemistry, and of course pharmacology all kind of link to it. Okay. So we know that the epidermis is there. You have the dermis below that, subcutis below that. Okay. And the epidermis has these layers: stratum corneum, lucidum, granulosum, spinosum, and basal. Okay. Now, So this is one question which was asked in the AIMS 2017. And the question is, which of these layers has an abundance of desmosomes? Okay. So the problem is that it doesn't give you the choice. It basically labels a certain part and says that which of these has an abundance of desmosomes. So what do you think is the answer? Okay, C. Why C? Ramya, Rahil, Varunka, any reason? Good. So basically, the stratum spinosum, why do you think it got its name? Got its name because, if you look at the stratum spinosum very carefully, you'll find that the cells are like this. They have these spines. Okay. And what are these spines? These spines are actually desmosomes. Okay. They're the cell-cell addition molecules. And because of those prominent desmosomes, they have this spinous appearance or a prickle-like appearance. So basically, desmosomes are most prominent in the stratum spinosum. And because of that appearance, it's also called the prickle cell layer. Okay. So stratum spinosum. Now, the clinical significance of the stratum spinosum comes in this condition. Okay. So what condition is this? And what do you think is happening over here? Almost a skin, and then it's almost like it's clefted over there. Okay. So which condition do you think this is happening? Histopathology. So imagine that you're seeing this on the skin. So a gap. So on the skin, what do you think the lesion will be? Good. So on the skin, what you'd expect is some kind of a blister. Okay, like a bulla or a blister. Good, very good. And this is pemphigus. Okay. And pemphigus desmosomes connection is the auto-antibody in pemphigus is directed against the desmosomes. Okay. So what happens is that E layer desmosomal attachments you start getting a blistering over there. And that is what essentially happens in pemphigus. Okay. So this appearance is called a row of tombstones appearance. Tombstones symmetry tombstones appearance because the top part is gone, the bottom, the cells kind of stick out. So this is called the row of tombstones appearance. It is characteristically seen in pemphigus, and the target over there is the desmosomes. Specifically, it is the desmoglines, which is the main protein in the desmosomes. Okay. So autoantibodies against the desmosomes, which leads to blistering. And because of that process, what happens is that normally prickle cylinder is prickles and pool. The cells separate out, so it leaves behind a big rounded cell without the prickles. And this is another characteristic cell of pemphigus. That's called the acantholytic cell. And why do you think it's called acantholytic cell? Acanthom spine. So acantholytic spine boy. The spine adichoy. So acantholytic cell. And that's what you typically get in pemphigus. Okay. Now, for the exam, pemphigus, bullous pemphigoid, dermatitis herpetiformis. These three items are usually questions. And mainly pemphigus versus bullous pemphigoid differentiate simple. Pemphigus is intraepidermal. Our blister formation is within the epidermis, while bullous pemphigoid is subepidermal. Bulla is formed below the epidermis. So when you think of it, it's something like this is pemphigus. You have a thin roof, while this is bullous pemphigoid, which has a thick roof because the whole epidermis is there above that. Okay. Confirmatory test for both is what is known as the direct immunofluorescence, which we'll discuss a bit later. So clinically, pemphigus is something like this. It's a bubble while bullous pemphigoid is more like a basketball. So it's very thick and doesn't break that easily. And the same thing translates into the clinical appearance.
So which is which? This is A, this is B. A endana, B endana. Good. Varunka, and any reason why you said A is pemphigus and B is bullous? You're right. Because like we said, normally pemphigus roof ഭയങ്കര thin ആണ്. So it's intraepidermal. So അത് പെട്ടെന്ന് പൊട്ടിപ്പോവും. So what the patient usually presents with is more of erosions rather than intact bulle. And in addition, you have desmoglines in the oral cavity also. So the patient also presents with oral erosions. Okay, so oral erosions, body erosions, flaccid bulle, which break easily. Think of pemphigus. Tense bulle like this are they are more suggestive of a subepidermal bullous condition like bullous pemphigoid. Okay, and mucosal lesions are less in bullous pemphigoid. So that is one point of differentiation. Now, quickly, എന്തായിരിക്കും ഇതിന്റെ treatment? Both of these they are grouped under what you call as autoimmune blistering dermatosis. So primary problem over there is autoimmunity. There are antibodies which react against desmoglein in the case of pemphigus. And in the case of bullous pemphigoid, there's a different set of antigens called BP 180 210, which are basically part of the hemidesmosomes in the basal layer. Okay, but both are autoimmune. So autoimmune varimba, what treatment do you think is given for both of these? Good. So the first line treatment is steroids. However, in pemphigus now, we have a new drug, which is a drug which acts against CD20 and thereby reduces the formation of antibodies itself. Which drug is that? Which has now become one of the mainline treatments for pemphigus. The problem with the treatment of pemphigus is that നമ്മൾ steroid കൊടുത്തുകൊണ്ടിരിക്കുമ്പോൾ steroidന്റെ side effect വരും, quality of life is to go down. So it was very difficult to manage. But now with this new drug, we can almost clear the disease. Which drug is anti-CD20 monoclonal antibody? Starting with R. RI. RIT. RI. New ille. Good. Rituximab. Okay. Right. So what earlier used to be steroids being the only option has now shifted over to rituximab as something which we use in quite a few patients with severe pemphigus. Okay. Bullous pemphigoid also we can use steroids, but then bullous pemphigoid is a milder condition. So in many cases, you can manage even with less dose of steroids and even topical steroids in some cases. Okay. Right. Now, one other question which is commonly asked is, നമ്മൾ പെംഫിഗസിൽ നമ്മൾ ഈ മേലത്തെ ലെയർ ഈ ഡെസ്മോസോംസ് പോയ കാരണം ഭയങ്കര ഒരു ലൂസായിട്ട് ഇരിക്കുന്നതാണ്. It's almost like a potato skin. So if you just kind of give force over the lesion, it peels off like the skin of a boiled potato. And that is called Nikolsky sign. So Nikolsky sign is basically an indicator that it's a, very superficial intraepidermal kind of lesion, classically seen in pemphigus. Okay. It can also be seen in some conditions like toxic epidermal necrolysis, but classically in the context of bullous disease, it is positive in pemphigus. It is negative in the case of subepidermal bullous disease like bullous pemphigoid. So clinical examination for all these bullous diseases, the investigation wise, three things which we do. One is called a Zank smear. One is a normal histopathology, and one is something called the direct immunofluorescence. In some cases, we also do an indirect immunofluorescence. So basically, these 4 items അറിഞ്ഞ, then you can make a diagnosis. Clinical history എന്താണ്, Zank smear finding എന്താണ്, histopathology എന്താണ്, IF എന്താണെന്നുള്ള. Okay. So for the exam, this is a simple summary. Pemphigus Zank smear, you get acantholytic cells, which we talked about. അതായത് നമ്മൾ prickle cell layer cells in the prickle wo. So what is left behind is a large rounded cell, which is called the acantholytic cell. Histopathology, you get the suprabasal blister with that tombstone-like appearance, which we talked about. Immunofluorescence, you get the IgG deposition intraepidermally. So it is within the epidermis, and that pattern is called a fish net pattern. Basically ഒരു മീനിന്റെ വല മാതിരിയുള്ള ഒരു അപ്പിയറൻസ് ആണ്. So it's called a fishnet pattern. Bullous pemphigoid Zangsmere shows eosinophils. Subepidermal ആണ്. And immunofluorescence pattern is C3 IgG along the basement membrane zone. So it is not intraepidermal but along the BMZ. Okay. The other condition which is commonly asked is dermatitis herpetiformis. That's confusing because dermatitis herpetiformis is subepidermal. But unlike bullous pemphigoid, you don't get large blisters, you get small papules and papulovesicles. Okay. So very blisters കാണാറില്ല. And very importantly, there is severe itching in this condition. അതിൽ Zangsmere we get neutrophils, subepidermal blister, and the antibody deposited is IgA. Okay. And it's basically the tip of the dermal papilla. So pemphigus, bullous pemphigoid, dermatitis herpetiformis. Pemphigus Zangsmere acantholytic cell, histopath suprabasal blister with the tombstone-like appearance, immunofluorescence, intercellular, intraepidermal, IgG, fishnet pattern. Bullous pemphigoid Zangsmere, eosinophil, histopath subepidermal blister with dermal eosinophilic infiltrate, IF C3 IgG along the basement membrane zone. Dermatitis herpetiformis Zangsmere shows neutrophils, subepidermal ആണ്. Very importantly, you get IgA. And like we said, a small difference in dermatitis herpetiformis is that itching is very severe. It can be associated with other systemic conditions like celiac flu and gluten intolerance. And another important point in dermatitis herpetiformis is that the drug of choice is not steroid, but dapsone. Okay. So most important pemphigus, bullous pemphigoid. Dermatitis herpetiformis is something which you ideally need to know. And something which is not asked very often, but just to be aware, is something called epidermolysis bullosa acquisita. You have antibodies against the collagen, which leads to blistering against subepidermal. So in areas like where patients have trauma and all, they tend to form blisters because of the antibody against the collagen of the skin. Okay. Okay. Now, just see if you can answer these questions. Okay. Direct question, and then answer. Good. So a simple question. So basically, when you get large, tense bulla, you think of bullous pemphigoid. And you think when you get flaccid erosions, flaccid bullae with erosions, you think of pemphigus vulgaris. What about this? Good. So, like we said, normally dermatitis herpetiformis it's slightly different. So, the lesions are more of papulovesicles, cherry lesions. Second thing is that the blister is subepidermal but shows IgA deposition instead of IgG. Itching is severe, and dermatitis herpetiformis. So it's like herpes. The lesions are grouped together. So correlations are in clumps, which is why herpetiformis. And what would the drug of choice be here? Very good. So like we said, drug of choice is dapsone, not steroids. Okay. Simple question. Good. So pemphigus, you get that nickel, see that peeling potato kind of thing. Again, simple question which you already discussed. Drug of choice for dermatitis herpetiformis. Good. Gluten sensitivity. Dermatitis herpetiformis. Good. Collagen in the basement membrane. Antibodies are seen in which condition? Not asked very often, but it is asked. Okay. So typically in the patients they have blisters, but they are on areas of trauma because of the antibody against the basement membrane collagen. So which of these conditions? Yep. So it is EBA, epidermolysis bullosa acquisita. So you get lesions like bullous pemphigoid, but the important thing is that it's more on areas of trauma. Okay, one more direct question related to anatomy. So epidermal melanin unit എന്ന് പറഞ്ഞൊരു concept ഉണ്ട്. അതിന്റെ എന്താണ് കണക്ക്? How many melanocytes to how many keratinocytes? Yeah, 36 is right, but രണ്ട് melanocyte ആണോ ഒരു melanocyte ആണോ? So basically, good. So basically, നമ്മൾ ഈ ഒരു melanocyte is a dendritic cell. Dendritic എന്ന് പറഞ്ഞാൽ basically it's like, it kind of gives out branches to the കുറെ ബ്രാഞ്ചസ് കൊടുക്കും ആൻഡ് ഈ ബ്രാഞ്ചസ് വഴി ട്രാൻസ്ഫേഴ്സ് മെലനോസോംസ് ടു ദി കെറ്റനോസൈറ്റ്സ്. ഓക്കെ, ആൻഡ് ദ റേഷ്യോ ഇസ് 1 melanocyte transfers to 36 keratinocytes. And this whole thing is what is called an epidermal melanin unit. So 1:36 ആണ് ratio. Okay. Okay. This is something which is asked many times. Okay. And it's not a very good question because, ഇത്ര information വെച്ച് മാത്രം, it's not easy to give a different diagnosis, but the answer they expect is only one thing. The answer. Like I said, it's not a very good question because answers can be a lot of things, but hypopigmented skin lesions വരുമ്പോൾ the few things which you need to remember for your exam is pityriasis versicolor. Normally ചുണങ്ങ് എന്ന് പറയുന്ന സാധനം. Pityriasis alba, which is kind of like an eczema, commonly seen in atopic children on the face, vitiligo, and leprosy. So ഇതിന്റെ വ്യത്യാസം വരുന്നത് വെച്ചാൽ pityriasis alba and pityriasis versicolor are hypopigmented, which means it doesn't turn completely white, it remains hypopigmented. And both of them show scaling. ഈ സ്കെയിലിംഗ് ഉള്ള കാരണമാണ് ഈ പിറ്റീരിയാസിസ് എന്നുള്ള പേര് വരുന്നത്. പിറ്റീരിയാസിസ് എന്ന് പറഞ്ഞാൽ നമ്മൾ ഈ പിറ്ററിയോൺ എന്ന് പറഞ്ഞാൽ നമ്മൾ അവലില്ലേ, ദാറ്റ് ഇസ് വാട്ട് ഇസ് റെഫർ ടു പിറ്ററോൺ. പിറ്ററോൺ ഇസ് ബ്രാൻ ഓർ അവല്. ഈ അവല് മാതിരിയുള്ള ഫൈൻ സ്കെയിലിംഗ് ഉള്ള കാരണമാണ് പിറ്റീരിയാസിസ് എന്നുള്ള പേര് പറയുന്നത്. സോ വെനെവർ യു ഗെറ്റ് ദാറ്റ് ഫൈൻ സ്കെയിലിംഗ് ഇൻ യുവർ സ്റ്റെം, തിങ്ക് ഓഫ് ദീസ് കണ്ടീഷൻസ്. And between these two, a point of differentiation is that pityriasis alba tends to be slightly ill-defined, clearly defined, while pityriasis versicolor tends to be more well-defined. Okay. So now, going back to the question, which do you think is the most likely diagnosis? Yeah, again, remember that in case it is, they have mentioned it as faintly hypopigmented macules with fine scaling. They have not really mentioned definition that well, but you're right. It could be pityriasis versicolor and alba, but then the answer expected by them is pityriasis alba, unless they specifically mention that it is very well defined. Okay. So pityriasis alba is the answer over here. It is not leprosy, primarily because scaling is not that common. And second thing is that sensory loss is പറയുന്നില്ല. Okay. Vitiligo illa because it's hypopigmented, not depigmented, like you get in vitiligo. So answer here is C, pityriasis alba. Okay. Again, a question which has been asked before. So hypopigmented patches are seen in which of the following? Nevus of aorta, ito, nevus anemicus, Becker's. ഇതാണ്. Many times നമ്മൾ ഒരു ഐഡിയ ഇല്ലെങ്കിലും the wording can give you a clue, because like a lot of things, dermatology also has a lot of Latin in it. Good. So nevus anemicus, as the name suggests, it's like the nevus is anemic. So almost a pale hypopigmented kind of lesion. While aorta, ito, and Becker's nevus are all examples of hyperpigmented nevi. Okay. So answer over here would be nevus anemicus. Okay. Not questions are not the not really ideal, but again, you do get a few questions in which of the following is given. Okay, so again, here remember that it is which of the following is not used in the treatment. So you need to make a diagnosis plus decide which is not used. So what is the diagnosis? Yeah, again, just think of 1 second. Yeah, just think of the color over there. So color കണ്ടിട്ട് എന്താ തോന്നുന്നു? It's a bit pinkier, but then compared to pityriasis versicolor and alba and all, do you think that it is more, less pigmented? Okay, rosacea. Anything else? Kalalla site. So rosacea, normally rosacea, the typical site is the face, cheeks. So here, I know it looks a bit pink, but the lesion is actually depigmented. It's almost white in color as compared to the surrounding skin. Okay, so whenever you get that kind of white discoloration, you think of vitiligo. Now the question is, vitiligo pathogenesis in the why vitiligo? What is the theory behind vitiligo? Color കുറയുക ചെയ്യുന്ന, so which means melanin is less. And melanin ഉണ്ടാക്കുന്ന എവിടുന്ന, which cell makes the melanocyte ആണ്. So vitiligo കുറേ theories ഉണ്ട്, but the most common theory is that it is autoimmune. In autoimmune എന്ന് പറഞ്ഞാൽ, you have antibodies acting against the melanocytes, leading to melanocyte destruction, which leads to depigmentation. Okay. So അതാണ് etiology angle. Which of these medicines would be useful? നമ്മൾ നേരത്തെ autoimmune blistering disease എന്ന് പറഞ്ഞപ്പോൾ which medicine was the drug of choice in pemphigus? Right. So again, we'll come to that. So basically, one of the things which you can use is steroids, right? Steroids which are systemically giving for something like vitiligo is something which we use only in some cases of vitiligo, which are generalized, rapidly spreading and all. So topical steroid is one option. One example of a topical steroid is clobetasol. So അത് കൊടുക്കാൻ പറ്റും എന്നുള്ളതാണ് ഒന്ന്. Like we said, topical steroids in a problem is that if you use it for a long time, it can lead to atrophy. അതായത് സ്കിൻ തിൻഡ് ഔട്ട് ആവും. ആൻഡ് വിറ്റ്ലൈഗോ ഇസ് എ കോസ്മെറ്റിക് ഇഷ്യൂ. ഇപ്പൊ നമ്മൾ atrophy ഇൻഡ്യൂസ് ചെയ്യണമെങ്കിൽ that defeats the purpose, right? So an alternative which we can use in vitiligo, which does not cause atrophy, is what is known as calcineurin inhibitors. അതിൽ രണ്ട് drugs ഉണ്ട്. One is tacrolimus, the other is pimecrolimus. These are topical preparations which can be used in conditions like vitiligo or even things like eczema and all those things. Okay. So clobetasol കൊടുക്കാം, tacrolimus കൊടുക്കാം. Methoxsalen എന്ന് പറഞ്ഞ സാധനം, so suppose this is vitiligo and you give immunosuppressant, steroid കൊടുത്തു or calcineurin inhibitor കൊടുത്തു, that will help in making the disease more stable. അതായത് അതിന്റെ ആക്ടിവിറ്റി കുറയും. But color തിരിച്ചു വരുന്നെങ്കിൽ, what do you need to add to the mix over there? Now, normally, when does the skin become dark? നിങ്ങൾ എപ്പോഴാണ് ടാൻ ചെയ്യുന്നത്? Sun exposure. So, which is why we use phototherapy using UV light as one of the treatments for vitiligo. And adinne potentiate ചെയ്യാൻ വേണ്ടിയിട്ട് one of the drugs which we use is something called seralins, one of which is methoxsalen. Okay. So, slightly difficult question, but the point is that you can use clobetasol, which is a steroid. You can use tacrolimus, which is a calcineurin inhibitor. You can use methoxsalen, which is a photosensitizer. Hydroquinone actually works the other way around. Hydroquinone എങ്ങനെ act ചെയ്യുന്നു? Any idea? And where is it used? Yeah, it can be used in scars, but then how does it act exactly? Hydroquinone inhibits certain enzyme, and that enzyme is the rate limiting enzyme in the synthesis of melanin. Which enzyme is that? Our enzyme from birth illegal that leads to albinism. So which enzyme are we talking about? Simple words, what is the problem in albinism? What is the defect in albinism? So that enzyme is tyrosinase. Okay. And hydroquinone is one inhibitor of tyrosinase. So it is used in conditions where there is hyperpigmentation, like for example, melasma. Okay. So the answer is hydroquinone. I hope it's clear. And if it's not, just you can stop me anytime. We can discuss it further. Okay. Right. So again, quickly, these are the commonest things which we ask in terms of hypopigmented skin lesions. Ill-defined, slightly scaly hypopigmented patches on the face of a child, dry skin under. Slightly more well-defined lesions on the face. Very well-defined lesions, almost white in color. So what is A, what is B, what is C? Let's start with this one. So വ്യത്യാസം എന്ന് പറഞ്ഞാൽ കുറച്ചും ഡിഫൈൻഡ് ആണ്, ഹൈപ്പോഗ്മെന്റഡ് ആണ്, സ്കെയിലിംഗ് ഉണ്ട്. ഇവിടെ not well defined, bit of scaling. ഇവിടെ very well defined, almost white in color. So we'll go with the easy one. ഇതെന്താണ്? Third one. Good. Third one is vitiligo. So depigmented macules, well defined on the face, you think of vitiligo. What about these two? A and the B and the, assuming that this is A. Good. So pityriasis alba. Okay. So again, it's not very easy to differentiate something, but generally a simple clue for your exam is that well-defined you think of pityriasis alba. While if it is slightly more defined, you think of pityriasis versicolor. Okay. But remember that for the exams, usually when they give pityriasis versicolor, they talk about truncal lesions, not the face. So when you see face lesions, most probably your answer is pityriasis alba. Okay. Okay. This we already discussed that answer. A. So like we said, tyrosinase is a rate-limiting enzyme in the synthesis of melanin. So tyrosinase koriyumbo pigmentation decreases, like you get in albinism. And that can be used in the treatment of things like melasma also, where you give tyrosinase inhibitors. Example is hydroquinone. Okay, this is again a very common question asked. So now we are talking about hyperpigmented lesions. And the important thing is that this type of lesion, it usually starts around puberty. So that's one of the key points which you'll need to look for in the stem. It starts increasing size usually around the puberty period. But it's hyperpigmented, slightly brown in color. And very importantly, if you look carefully, you'll find that there's increased hair in that area. Okay. This is something called Becker's nevus. So key points to remember is young adult, shoulder area is the most common, hair tends to be prominent, and these are the other conditions which come with hyperpigmentation. Okay. Now, ഇതിൽ commonly ചോദിക്കുന്ന രണ്ട് question is E ഒരെണ്ണം E ഒരെണ്ണം. Any idea what these are? കുറച്ച് രസമുള്ള പേരാണ്. And they sound similar. Both are nevus of something. Japanese names ആണ്. So, രണ്ടിലും സംഭവിക്കുന്ന വെച്ചാൽ you have dermal pigmentation. These are both examples of dermal hypigmentation. One is on the face, around the eyes. One is on the acromial clavicular area. Okay. This is called nevus of aorta. Good. While if it comes on the other area, it's called nevus of Ito. Okay. So, Ota, simple way of remain thinking of it is that Kanninte chuttum, Ota chuttum varayengil, you think of Ota, while if it comes on the other area, you think of nevus of Ito. So, both dermal nevi, Ota and Ito. Then very common young babies disappears with age. Another example of a dermal nevi. Small babies in a vacuum, then gradually disappears. It's called as a Mongolian spot. It's another example of a dermal nevi. Dermal nevi clue color it's almost like a slightly grayish blue color, while when it's more superficial, it tends to be more of a brownish color. Okay. So Mongolian nevus or Mongolian spot. This we discussed before. So young patient, shoulder, hair growth. This is what? Previous question. In the nevus son. Becker's nevus. Okay. And this is easy. This is congenital melanocytic nevus. And this one is not a nevus, but a very common condition, which is seen in female patients in two age groups. One is during pregnancy and one is postmenopausal. That is, then diagnosis melasma. Very good. Or cloasma. Okay. So pigmented lesions, these are the things you need to keep in mind. So nevus of Ota around the eye, Ito, acromoclavicular, Mongolian spots in babies, dermal nevi, Becker's nevus, shoulder, hair growth, young adult, congenital melanocytic nevus, baby, hair growth is there, and melasma, females either during pregnancy or postmenopausal. Okay. So, the diagnosis, ABCD trilla, but assume that it is an order. So, ABCD. A. So, like we said, Kanninte chuttum nevus of Ota, and often that can be associated with scleral pigmentation also. Good. Okay. Arani alkare, and what is common between these? One Chetan is flying a kite while there is thunder and lightning. Another famous lady and historical figure from Russia. Which is which and what is common? Dharana, lightning, kite varpikkunna ആള്. ഇതൊന്നും എൻട്രൻസിന് വരില്ല, ജസ്റ്റ് വേറൊരു കോൺടെക്സ്റ്റിലാണ് ചോദിക്കുന്നത്. Benjamin Franklin. Okay. And the lady, I think most of you will be knowing. ആരാണ്? Nobody? Lady is Kim Kardashian, and this person over here is Stalin. And why I put this is because all of them are linked because they are said to have psoriasis, have had psoriasis in the case of two people, while Kim Kardashian is said to have psoriasis. Okay. So psoriasis is a very, very common condition. And it is an example of what we call as a papilloscomus disease. Papilloscomus it's a combination of papules with scales. Okay, papules or plaques with scales. Basically, raised skin lesions with scaling papilloscomus. They're not flat, they're raised. They tend to be scaly. Most of them tend to be slightly erythematous or slightly violet in color in some cortex, which will come to later. So these conditions are together referred to as papilloscomus disease, of which the most common is psoriasis. Okay. Now, we'll just quickly go through what is most important in psoriasis, lichen planus, and pityriasis rosea. These are three things which are covered over here, and then we'll go to the MCQs. Okay. I'm going a bit faster, but any point you want to stop me, and then we can stop and discuss. Okay. So psoriasis, the key points to remember is number one, the lesions are well-defined, erythematous, red, scaly plaques. Okay. The scales are typically described as silvery white. So white scales are, but added description that is silvery white in color. The commonest sites are the ones which are shown over here. So extensor surface of the knees, the forearm, elbows, lumbosacral area, the scalp. Okay. Now, to understand the rest of the story of psoriasis, just think of the pathogenesis. So, our kanana items, you're seeing redness, you're seeing scaling, and the skin is thick. Okay, so the three things happening over there. Normally, when the skin is red, what do you think is happening? Why do you think the skin is red? Very good. It's primarily due to inflammation. So earlier, it was said that one of the primary issues in psoriasis is that some problem in the skin cycling process. The skin cells were, cycling faster. They were moving to the stratum corneum faster, getting converted to scales faster, and so on, which is there. But what triggers that is actually the inflammatory process. So now we know that psoriasis is basically a T cell mediated disease. And that the main mediators in psoriasis are things like TNF alpha. You have interleukin 12, 23, interleukin 17, and so on. There's a big list. Okay. So it is said that these things cause inflammation, which in turn causes a lot of things like increased skin exfoliation, increase in the skin turnover, reduction in the skin cycling time, and so on, which leads to the increased scales, the redness, and the thickening of the skin. So this is basically the story with psoriasis. Okay. Now, if this is the story, what would your treatment be? Okay, right. So basically, psoriasis treatment we can divide into topical, systemic, and others. Others, basically what you're talking about is phototherapy. Okay. Primarily, most common treatment we use is topical or systemic, and the differentiation between whether you give topical or systemic is based on the factors like severity, like large area of the body involved only you prefer systemic. Smaller areas, topical should be good enough. Okay. Or if there are complications, which complication systemically can occur in psoriasis? Which other system is classically involved in psoriasis other than the skin? Psoriatic patients might come to you with pain where, good. So psoriatic arthritis. Obviously, psoriatic arthritis and lingulam, you cannot manage with topical treatment. So you have to give systemic treatment. Okay. Now, topical treatment, start with a simple thing. Skin dry. So what can you give for the dryness? There's a lot of scales, dry. So what would be the simplest thing you can give? Good. So moisturizers, emollients. So that would be the first thing you can give. The second is the skin is thick. There is hyperkeratosis. The scales are getting accumulated. So you want to remove that excess keratin. So you give a keratolytic. And what is the commonest keratolytic which we use in dermatology? Some acid. Common thing which we give is salicylic acid. Okay. Good, Ramya. In addition, the inflammation needs to be controlled. So you can give a topical steroid. So in simple cases of psoriasis, this is the simple thing which is required. So emollients, steroids, and salicylic acid, topical steroids. Systemic steroids are not used in psoriasis because അത് കൊടുക്കുമ്പോൾ psoriasis മാറുമെങ്കിലും it tends to rebound very badly. Okay. So remember that systemic steroids are not given in psoriasis as a rule. But if it is more extensive psoriasis, then you need to go for systemic treatment. Now, think of the pathogenesis again. So, there is this abnormal cell division, cell turnover, all those things. Second thing is there is the inflammatory process. So, what drugs can you use systemically in psoriasis? Topical or systemic treatment? Tacrolimus, okay, tacrolimus we can give topically, although it is not that effective in psoriasis. But yes, it is one of the drugs used topically. Good, Nazir. So systemically, the first line treatment for psoriasis is methotrexate. Second is acitretin, which is a systemic retinoid. Then you have things like cyclosporin. Okay. You have other immunosuppressants also, like cyclophosphamide, mycophenolate mofetil, and all those things. But these are the classical 3 drugs used in systemic psoriasis: methotrexate, acitretin, cyclosporin. However, now we have an entire new group of drugs based on our cytokines. So we said that there are certain cytokines which are involved in psoriasis, like TNF alpha, interleukin 12, 23, 17. Adinne target ചെയ്യുന്ന ഗ്രൂപ്പിന് എന്താ പറയാ? So you have monoclonal antibodies which can target these cytokines. What is it called, that group? Which is used not only in psoriasis, but also conditions like rheumatoid arthritis, inflammatory bowel disease, and all. Most of them are monoclonal antibodies. So they end in MAB. Which MABs are used in psoriasis? Good. So ixekizumab is one thing, but of course there are the older ones available like adalimumab. You have secukinumab. So adalimumab, for example, is anti-TNF alpha. Secukinumab is anti-IL-17. Ixekizumab is also anti-IL-17. But just remember that you have a whole group of biologics available. They're called biologics, this group as a whole, which can be used in psoriasis. And of course, finally, you have that option of phototherapy. This is the basic concept of treatment of psoriasis. The other questions you get sometimes is triggers related to psoriasis, which means what are the things which can make psoriasis worse? For example, which climate does psoriasis become worse? Winter lana, summer lana? Very good. So multiple reasons. One is that the skin becomes drier, but along with that, the other issue is that sun exposure is less. Okay. And we know that UV is useful for psoriasis. So that is probably another reason why it flares in winter. So triggers for psoriasis include climate, stress, some drugs, especially beta blockers, NSAIDs, lithium. Withdrawal of steroids. Like we said, steroid is not a good idea for psoriasis, but for some other reason, if the patient has taken steroid and they stop it suddenly, that can lead to a worsening of psoriasis. Okay. So these are some of the triggers of psoriasis. And finally, you need to know some types of psoriasis. So, we talked about the word vulgaris. Vulgaris means? What is the word meaning? Good. It means common. So the common type of psoriasis is psoriasis vulgaris or chronic plaque psoriasis. That's what you saw in the previous image. So chronic plaque psoriasis, typically seen over extensive surfaces, scalp, lumbosacral area, and so on. Now, a test which is very important for your exam again is this thing. So, നമ്മൾ psoriasisന്റെ lesion എടുത്തിട്ട് നമ്മളൊരു glass slide എടുത്തിട്ട് അത് scrape ചെയ്ത് തുടങ്ങിയ after a point you'll find a smooth membrane-like thing. പിന്നെയും scrape ചെയ്ത് you find small bleeding spots. And this is often asked in the exam, and this sign has a name. What is this sign called? Good. It's called the Auspitz sign. Okay. And the test is sometimes also referred to as the Grattage test. So basically, Auspitz എന്ന് പറഞ്ഞാൽ നമ്മൾ ഈ സോറിയാറ്റിക് ലീഷൻസ് ഒരു ഗ്ലാസ് ലൈറ്റ് എടുത്തിട്ട് സ്ക്രേപ്പ് ചെയ്ത് തുടങ്ങിയാൽ ഒരു ചെറിയൊരു ഫൈൻ മെംബ്രെയിൻ മാതിരി കാണും. അത് പിന്നെയും സ്ക്രേപ്പ് ചെയ്ത് തുടങ്ങിയാൽ യു ഗെറ്റ് ദിസ് fine bleeding points over here. And that is called the Auspitz sign. Okay. The other thing you get in psoriasis is that any injury or trauma can lead to new lesions. So we scratch scratch lesions. That's called what phenomenon? Very good. That's called the Kobna phenomenon. Okay. It's not seen only in psoriasis, but it is very characteristic of psoriasis. So Kobner phenomenon. So Auspitz sign, Kobner phenomenon. Okay. Now coming to the types of psoriasis, what is missing over here? Psoriasis pictures picture compare picture missing. The scales are missing. And why do you think that is missing? Because it is on the axillary area. So areas where the sweat tends to accumulate, axilla, groins and all, psoriasis presents with a smooth appearance without much of scales. And this type is called flexural psoriasis because of the site, or inverse psoriasis. Why? Because psoriasis normally is extensor. Extensor surfaces la. So here it is opposite of that, which is why it's called inverse psoriasis. Okay. Often it can be mistaken for a fungal infection, but when you take a biopsy, you find that it is psoriasis. Right. Psoriasis can sometimes come either limited to or also involving the palms and soles. And that is referred to as palmoplantar psoriasis. Okay. Then in the how are the lesions different over here? So you saw those large scaly plugs in the previous cases. Even appearance-wise, how are the lesions different? This is also psoriasis, but so size-wise, it seems to be much more smaller. This is also often asked in the exam, and this is something referred to as what psoriasis? Well, guttate psoriasis. The gut word in French, it means drop like. Okay. So drops appearance, and which is why it's called guttate psoriasis. 3 points you need to remember for guttate psoriasis. 1, size is less, more common in children, better prognosis, and it is associated with streptococcal infections. Basically, ഇത്രയും ഓർത്ത് വെച്ചാൽ മതി. പിള്ളേരിലെ കോമൺ ആയിട്ട് കാണുന്ന ചെറിയ ചെറിയ ലീഷൻസ് ആയിട്ട് കാണുന്ന prognosis is better as compared to chronic plaque psoriasis, and it has a very strong association with streptococcal infection. So most of the children, they will say that they had a sore throat 2 or 3 weeks before the lesions start coming. So guttate psoriasis. This we just discussed before when we showed the primary lesions. So initially the patient comes with scaly plaques, but then they develop pustules. So this is called what psoriasis? Pustular psoriasis. Okay. And the important thing in the exam is that remember that in pustule, there is no bacterial growth. We culture bacteria because it's a sterile pustule. Okay. The pustule is basically because of infiltration of neutrophils. So this is one example of what you call as a sterile pustule. There is no bacteria as such. Okay. Right. And of course, when you have the whole body involved with psoriasis, by definition, more than 90% of the body surface, we call it as exfoliative dermatitis or exfoliative psoriasis. The other term is erythroderma. Okay. Nail changes. Again, a lot of points, but remember that the most common nail change that you get in psoriasis is this thing over here. Very good. It's called pitting. But the most typical nail change is this thing. It's like, you put a small drop of oil below the nail. So which is why it's called a what sign? It is subungual, but subungual hyperkeratosis is slightly different. This is called the oil spot sign or oil drop sign. Good. So that is said to be the most typical nail change, but the most common is nail pitting. Okay. You can get splitting of the nail plate from the nail bed, which is called onycholysis. And you can also get total nail dystrophy in some cases. Okay. Arthritis is very common in psoriasis. And the most classical type of psoriatic arthritis is involvement of the distal interphalangeal joint, the DIP, as compared to rheumatoid, where it is the proximal interphalangeal. So here, distal is more typical, but any joint can be involved. Okay. This we already discussed. So climate, drugs, infection, stress, steroid withdrawal. Treatment we went through quickly, but we'll try to cover that again. So topical treatment, emollients, salicylic acid, corticosteroids. There are a lot of other options, but these are the common things which we use. Systemic, methotrexate, retinoids, and biologics. You can also use cyclosporin, mycophenolate, and phototherapy. Okay. Okay, now quickly going through the MCQs, then answer. So like we said, Auspitz sign. So you scrape the lesion, you get those small bleeding spots. That's called the Auspitz sign. Okay. So again, the question is, which is not a manifestation of psoriatic skin lesions? Very good. So basically, oozing and crusting is more typical of dermatitis. So that's seen in eczemas, but not so in psoriasis. Okay, so in psoriasis, you can get erythema, you can get scaling. And pustular psoriasis, you can also get pustules. But as a rule, you never get oozing and crusting in psoriasis. So answer would be B. Question is commonest nail change. So answer is pitting. Good. So pitting is the commonest one, but the most typical one is the oil spot or oil drop sign. Classical joint involved is A. So psoriatic arthritis, like any joint can be involved. There are different patterns, but the most classical is the distal interphalangeal joint. Again, would be an easy question because biologically mab it's automatic. But then in some of the questions, you might get different mabs used for different conditions. So you might have to just go through briefly which are used specifically in psoriasis. Again, remember the basic idea. So the cytokine is what decides which is used in that condition. So you put a TNF alpha, interleukin 12, 23, 17, and typically the ones which are involved. So you use ones against that. In pemphigus, we target CD20 to reduce the formation of antibodies. So there we use rituximab. Okay. Right. So shifting over to the next condition and then diagnosis. The clue to the diagnosis is the color. What is the color? Very good. So it's lichen planus. The lichen planus in a typical thing is the 5 Ps. And then a 5 Ps. So very good. Purple. So basically the lesions are papules or plaques. The color is purple. Good. The main symptom is pruritus. The shape is said to be polygonal and the surface is said to be planar, which means, it's raised, but the top is like a shelf. Okay. So 5 Ps, papules, plaques, purple, pruritus, polygonal, planar. Okay. So this is another example of a papilloscomus disease, severely pruritic. Exact etiology is not known, but probably has some kind of autoimmune process going over there. Lichen planus. Okay. And why lichen? Because lichen is another name for normal tree moss lichen, and looks a bit similar is what is the concept. Now, for the exam, the 5 Ps, plus remember that lichen planus typically can involve the oral cavity. So you can get oral lichen planus. in almost more than 50% of the cases. Okay. Ivideum, you can get a Koebner phenomenon. The most common site is the flexor areas of the wrist and the shin area of the legs. Okay. So just a few points that should be good enough for lichen planus. This is oral lichen planus, or a whitish, almost candidates, but if you look carefully, there's a bit of a lacy network-like pattern. Okay. This is the Koebner phenomenon seen in lichen planus. So you see lesions in lines because areas of trauma, scratching and all, you get new lesions. Okay. This is another important thing for the exam. Normally, a lichen planus lesion, careful or lens which or a drop of oil to nokial, you get white striations on the surface. And these striations are very typical of lichen planus, and they're called Wickham's striae. Basically, white striations on the surface of lichen planus lesions. Okay. Lichen planus nail changes varam, and you can get a lot of nail changes, but the most typical nail change is this wing-like appearance. Wing-like appearance very good. So it's called pterygium, and the same thing is what we call the nails. It's called nail pterygium. Nail pterygium is the typical feature of lichen planus. It's a benign disease. Mainline treatment is topical and systemic steroids. Tends to recur and relapse. Okay. Are you still following or madhyaya, tired? Can we go on? Okay, right. So I'm just going a bit faster now, but again, if there's any doubts, you can either stop me right now or you can ask me later. I'll be sharing my email address also. So then you'll email you the message. Okay, right. So, next papillus commons disease is this thing. Again, very commonly comes in the exam. Adinte few key points you need to remember is one, this rash starts as a single rash. It's a real rash to start team. One or lesion, typically one lesion. And then the whole body gets affected. So first there is a single lesion, and then it starts becoming generalized. Usually asymptomatic, but there can be a bit of itching. And the individual lesion has this kind of annular kind of appearance with the scale being arranged in the periphery. Scaling in a edge scale. So what are we talking about? What is this condition? Very good. So it's called pityriasis rosea. Yeah, tinea would be a differential diagnosis, but then with this whole story, tinea seems unlikely. So tinea, patch and then it starts generalizing. And usually after a month or so, it starts disappearing by itself. Okay, so this is a typical progression of this condition called pityriasis rosea. And like we said, why pityriasis? Because of that fine scaling. Why rosea? Because it's red in color. Okay, so red scaly lesions with that slightly annular appearance. Pityriasis rosea, the typical points to remember is one is that progression. The story which we talked about, single lesion then spreading generalized, relatively asymptomatic. And this scale has a typical appearance which is called a collarette scale. Collarette it's like a collar. നമ്മുടെ ഷർട്ടിന്റെ collar മാതിരി ആ എഡ്ജിൽ മാത്രം ഇങ്ങനെ നിൽക്കുന്ന ടൈപ്പാണ്, which is why it's called a collarette scale. Okay. So pityriasis rosea. So self-limited ആണ്. So it starts with one single patch which is called the herald patch or the mother patch. Herald because it starts the eruption. So it's heralding the eruption, which is what's called herald patch. And then it becomes generalized. So this is the herald patch. And when it becomes generalized, the appearance is like a Christmas tree, especially on the back. So this pattern is called Christmas tree pattern. Okay. And this is the collarette scale which we talked about. Collar madriyana. So you can see that the scale on the edge over here. Etiology is not known for sure, but now it is considered to be due to HHV 6 and 7. Human herpes virus 6 and 7. Okay. Now, idum pitches rosette in the connection. What is this? So you have the same type of rash, young adult male, and the extra clue is that he had a genital ulcer a few days before. So which other condition can look like very good? So secondary syphilis. Okay. So secondary syphilis is one important differential diagnosis of pitches rosea. Okay. Which is why if you get a case of pitches rosea, one of the tests which you need to do is to rule out syphilis. So which test would you do to rule out syphilis? This is Treponema pallidum. Okay, so what you're seeing over is Treponema pallidum. The good. The test is VDRL or RPR. Okay, good. So clinical diagnosis, biopsy, and VDRL to rule out syphilis. Self-resolving, but you can use emollients, you can use topical steroids for the itching, you can use antihistamines. But most important thing is counseling, hand-holding, and telling the patient that it is self-limited. Right. So which of the following is true regarding pitches rosea? Simple question. So self-limited, Anna. That's the most important thing which you would tell the patient also. Not diagnosis. Good. So the point is that lichen planus can present with oral lesions, number one. Number two, the appearance of the oral lesions typically is in the form of white reticulate, net-like streaks, and it can be painful in many patients, burning pain and outcomes. Okay, so this is oral lichen planus. Generally, of course, the rule is that if all of the above is there, it should be all of the above. But now, of course, all of the above questions are less as compared to before. So common triggers of psoriasis include NSAID, lithium, beta blockers, antimalarials. Okay. So all of the above. Right. As we already discussed, simple question. Auspicious sign. Okay, good. Good. So ഗട്ടിയിട്ട് നമ്മൾ പറഞ്ഞ 3 പോയിന്റ് എന്ന് പറഞ്ഞാൽ ഒന്ന് more common in children, post-streptococcal typically, and better prognosis. Of course, why gutted? Because it's small lesions. So streptococcal sore throat into പെട്ടെന്ന് കുറേ ചെറിയ lesions ആയിട്ട് വന്നാൽ you think of gutted psoriasis. Okay. Severe pruritus ഏതിലാണ് കാണുന്നത്? It is not that you cannot get pruritus in the others. You can get in all, but in general, when the pruritus is very severe, you think more of which condition? You think more of lichen planus. So psoriasis-ലും pruritus ഉണ്ടാവാം, pitches rosea-ലും pruritus ഉണ്ടാവാം, but it's not very typical, and usually it's not very severe. But lichen planus is characterized by pruritus. So one of the P's itself is pruritus. So answer is yes, it's lichen planus. Differential diagnosis of pitches rosea. ഏത് syphilis ആണ്? It is secondary syphilis. Okay, primary syphilis, and you're talking about the genital ulcer, the chancre. Tertiary syphilis is things like gamma and all those things. So here you're talking about secondary syphilis, skin rash, mucosal lesions, lymphadenopathy. So pitches rosea is a differential diagnosis for secondary syphilis. Good. There are 3 or 4 pointers towards the diagnosis. So it should be simple. Yeah, good. Child learner, streptococcal infection history, and there was a good prognosis. So all of them indicate that it was probably gutted psoriasis. Which of the following can exacerbate psoriasis? Good. So we said that classical drugs which can cause exacerbation of psoriasis is NSAID, beta blockers, lithium, antimalarials. So here the answer would be propranolol. Okay. Good. This we discussed. Okay, quickly we'll try to finish acne also. Now acne when you think of acne, again, you get a few questions in the exam. Important things to remember is one is the pathogenesis. So why acne? എന്തുകൊണ്ടാണ് acne വരുന്നത്? Acne primarily affects the pilosebaceous apparatus. So you have the sebaceous gland, you have the hair linked to this. Pilosebaceous, and pilo means hair, and the sebaceous gland. So that whole unit together is called the pilosebaceous apparatus. And what happens in acne usually, as the first thing, is that ear duct, the sebaceous duct, is lined by epithelial cells. And like every area, you have the cells dividing, getting removed, and that cycle continues. That duct remains open. Okay. Acne, these cells become abnormal. They're kind of sticky. They're not removed properly. And the net result is that this area becomes clogged with keratin. Okay. And which is why this is called a keratin plug. So once that opening is plugged, but the sebum is still being secreted over here, what will happen? അതായത് ഗ്ലാൻഡിൽ sebum secrete ചെയ്യുന്നുണ്ട്, പക്ഷെ ഓപ്പണിംഗ് ഇല്ല. It's blocked over there. So what will happen is that the sebum starts accumulating. And ഈ accumulated sebum പുറത്തോട്ട് push ചെയ്യുമ്പോൾ you'll find something like a bump, and in the middle of the bump you have that's blackish material, debris-like material. What is this lesion called? ചെറിയൊരു papule മാതിരി, and നടുക്ക് ചെറിയൊരു കറുത്ത കുത്ത്. Yeah, it looks like a sebaceous cyst, but then you're talking about very, very small lesions. So adinu എന്താ പറയാ, good. It's called a comedone. Okay. So നമ്മൾ normally പറയുന്ന black head, white head എന്ന് പറഞ്ഞ സാധനമാണ് ഈ കാണുന്നത്. And black head and white head difference എന്ന് പറഞ്ഞാൽ the black head is otherwise called an open comedone, which means air enters and oxidizes the melanin over there, turns it darker, which is why that debris looks black. While closed comedone എന്ന് പറഞ്ഞാൽ it is completely closed, so no air enters and the keratin remains white. So white head. Okay. So white head is closed comedone, black head is open comedone. പക്ഷെ ഇത്രയും മാത്രമാണെങ്കിൽ you cannot explain the inflammation over there. So this explains the comedone formation, which is the primary lesion of acne. But why does it become red, inflamed, pus formation, cyst? അതൊക്കെ എന്തുകൊണ്ടായിരിക്കും വരുന്നത്? So what other factor is going on in acne? Normally, നമ്മൾ റെഡും ഇൻഫ്ലെയിംഡ് ആവണമെങ്കിൽ what do you think of? You think of infection. So which bacteria is involved in acne? What is the bacteria involved in the pathogenesis of acne? The bacteria is called, good. It used to be called Propionibacterium acnes. Now the name has been changed to Cutibacterium acnes. It's a commensal, and it's an anaerobic bacteria, which means it is already there in the sebaceous gland, but when the sebum accumulates, it starts dividing, causing inflammation that leads to pustule formation, all those things. Okay. So now, theoretically, when you think about it, you can treat the abnormal keratinization. You can remove the plug. You can treat the keratinization over here. You can treat the bacteria. Plus, you can try to reduce the sebum secretion, right? So, എങ്ങനെയൊക്കെ acne treat ചെയ്യുക based on this? The easiest thing would be to target the bacteria. So, which antibiotic do you use in acne? Topically, either use ചെയ്യുന്നത്, systemically, either use ചെയ്യുന്നത്? Good. So, topical clindamycin is probably the most common one which you use in acne. Systemically, you've got doxy, you've got azithromycin, you've got lincomycin, you've got minocycline, and so on. Okay. So, that is one part. More importantly, you put this plug over here. Our plug, only you need to deplug it, or you need to make the differentiation normal. Okay. So that it doesn't get plugged again. So അതിന് commonest ആയിട്ട് യൂസ് ചെയ്യുന്ന സാധനം is retinoids. Okay. And retinoids, are topical and systemic. Topical retinoids, the one which we use most commonly now are adapalene, retinoin, and so on. And systemically, you have isotretinoin. Okay. Other drugs which you can use is something called benzoyl peroxide. So these are the common things you can use in acne. Okay. Another point is the differential diagnosis. When you get acne-like lesions on the face or body, there are a few other things which you need to consider in the differential diagnosis. Like what? Let's rub this. Okay. So one thing which you always need to differentiate from acne when it comes on the face is this condition called rosacea. So I think we just mentioned rosacea. Rosacea is because it looks red like a rose. Important points to differentiate are that number one, there are no comedones. Okay, blackheads, whiteheads, the lesions are papules, pustules, and very prominently you've got these red lesions which are due to dilated blood vessels, which are called telangiectasia. Typically appears on the central area of the face. Nose, cheeks are typically involved. Very common in females. Triggers can be sunlight, stress, hot, spicy food, and so on. So it's called rosacea. Most important point, no comedones. Okay. Second thing is steroid-induced acne. So when you take systemic steroids that can induce acne-like lesions, again, comedones are not seen. Plus, it's more common over the trunk as compared to the face, as compared to normal acne. Okay. So rosacea and steroid-induced acne. These are two things which you need to keep in mind as differential diagnosis. Mainly it's a clinical diagnosis, but then laboratory examinations are important in the context of especially female patients with associated hyperandrogenism. So things like polycystic ovarian disease, you need to work up for other associations. And the other investigation you would do is in a patient with severe acne, if you're planning to start systemic retinoids, there you need to investigate for liver function test and the cholesterol levels, the lipid profile, especially triglyceride levels. Right. Treatment we already discussed. So now, quickly, drug of choice in nodal cystic acne. എല്ലാവരും ഉറങ്ങിപ്പോയോ? Again, remember that when you say nodulocystic acne, especially when it is painful, you are thinking about slightly more severe kind of acne. Okay. So, കുറെ lesions ഉള്ളപ്പോഴും, നമ്മൾ large lesions ഉള്ളപ്പോഴും, generally topical treatment is not enough. Right? So, the systemic would be the drug of choice. So, your topical clindamycin, topical adapalene goes out. ഇനി ബാക്കിയുള്ളതിൽ which one do you think is the most effective treatment for nodal cystic acne? Antibiotics which കുറയുമായിരിക്കും, but then it doesn't sustain that. So long-term relief is with oral retinoids. Okay. So the answer is oral isotretinoin. Basically, just remember that severe acne treatment of choice is oral retinoids. The name of the drug is isotretinoin. Okay. The only problem is isotretinoin chumma തുടങ്ങാൻ പറ്റില്ല. So you need to do your liver function test, your lipid profile, especially the triglycerides. In female patients who are married, very good. You need to rule out pregnancy because it is tetogenic. It is tetogenic. So you have to make sure that the patient is not only that she's not pregnant, but also that she's not planning to get pregnant while she's going to take the drug. Okay. So oral retinoids, isotretinoin. Right. So again, remember that for acne, one of the common questions which comes is related to oral retinoids. Now, all this can occur. But what is the commonest side effect is the question. The commonest side effect is dryness. Good. So typically it presents as, lip dryness and inflammation, which is called cheilitis. Okay, retinoid cheilitis. So the commonest thing would be dry skin. But then you're right. One important thing which you need to keep in mind as a complication is tetogenic. Right. Okay. Most likely diagnosis. Good. So like we discussed, rosacea, key points to remember: face, telangiectasia, red in color, worsening on sun exposure, stress, hot spicy food, female patient, and very importantly, no comedones. Okay, so this would be rosacea. So the last section is eczema. I'll again, Pathu and Tondu will try to finish that quickly. What do you call in inflammation of the skin? Inflammation of the liver is hepatitis. So അതേ മാതിരി inflammation of the skin എന്താണ്? Inflammation of the skin would be dermatitis, right? Liver hepatitis inflammation of the skin is dermatitis. Eczema is considered to be one kind of dermatitis. It's a subset of dermatitis where you have certain, typical features. എന്താണ് typical features? That is, when do you call eczema? When do you call dermatitis as an eczema? അതിന് typically it has a clinical pattern. So it goes through stages of acute, subacute, chronic. And histologically, you have this typical feature which is called spongiosis. Spongiosis എന്ന് പറഞ്ഞാൽ നമ്മളിപ്പോൾ ഒരു എക്സീമേറ്റഡ് പേഷ്യന്റിന് നമ്മളൊരു ഹിസ്റ്റോപത്തോളജി എടുത്തു നോക്കിയാൽ യു വിൽ ഫൈൻഡ് എംപ്റ്റി സ്പേസസ് ഇൻ ദി എപ്പിഡോമിസ്. ഈ എംപ്റ്റി സ്പേസസ് are because of collection of fluid. And when you think of it, it looks like this. Sponge മാതിരി ഇരിക്കും, which is why this change is called spongiosis. Okay. So if a dermatitis patient fits into either acute, subacute, or chronic stages, and histology, you can find the spongiosis, then you can confirm that it is eczema. Okay. We don't do a biopsy in all patients, but theoretically, spongiosis is the typical feature of eczema on histopathology. Now, the word eczema is derived from the Greek word exene, which means to boil. And why the relation comes because in severe acute eczema, it's almost as the skin is boiling. നമ്മൾ പൊട്ടി വെള്ളം വരുന്ന തിളച്ച് പൊങ്ങുന്ന മാതിരി ഒരു appearance, and which is why the origin of the word came exene, which means to boil. Classification according to stage, like we said, is acute, subacute, chronic. And ഇത് മനസ്സിലായാൽ തന്നെ your treatment part becomes easy. Acute eczema എന്ന് പറഞ്ഞാൽ the inflammation is acute. So you have all inflammatory features. Red, it's edematous, there's fluid, vesiculation, oozing and crusting and എല്ലാം ഉണ്ട്. Subacute എന്ന് പറഞ്ഞാൽ the inflammation is, so this combination is called lichenification. Okay. So chronic eczema, hallmark feature is lichenification. Okay. So acute, severe inflammation, subacute, redness, a bit of scaling, while chronic, you get lichenification. Okay. Eczema is also classified into endogenous, exogenous. Endogenous, the primary cause inside the body is dermatitis. And this is another example. For example, we said that some eczemas are exogenous. So, for example, photodermatitis, that would be the first thing. If it's contact with something, you avoid the stage of eczema. Okay. So just quickly, eczema inflammation. Okay. So what topical medicine would you use most commonly to control the inflammation? Very good. So use topical steroids. The patient has itching as the primary symptom. So what will you add on? Itching control item. Antihistamine. Very good. And in this particular stage, the skin is kind of broken down. So putti and irrigation. So what is the risk over there? What can happen? Good. So there's a risk of infection. So you add an antibiotics. Okay. So basically, the treatment of acute eczema is topical steroids, antibiotics, antihistamine. Plus, in addition to control the oozing, we give saline compresses. Okay. So that is acute. Subacute, oozing illa, crusting illa. So your risk of infection is out, right? But avadeyum, there is inflammation and there's a bit of dryness coming into the picture now. So topical steroid, yes. Antihistamine, yes. But what would you add to it to control the dryness? You add a moisturizer. Good. So basically, steroid, antihistamine, moisturizer. Any moisturizer. You can use liquid paraffin, Vaseline, whatever it is. Chronic eczema, lichenification ആണ്. So അവിടെ itching ഉണ്ട്, dryness ഉണ്ട്. So moisturizer ഉണ്ട്, the antihistamine ഉണ്ട്, steroids use ചെയ്യാം. But the problem there is that skin is thick, so the steroids don't penetrate that well. So you need to add something which kind of, makes it less thicker. And the thickness is due to keratin, right? So you give a keratolytic. And we discussed before that what is the commonest keratolytic which we use on the skin? Very good. Salicylic acid. So, okay. So topical steroid, keratolytic like salicylic acid, antihistamine, moisturizer. So this is the basic concept of treatment eczema. You identify the trigger, and if possible, you avoid the trigger. Plus, you treat according to the stage, whether it's acute, subacute, or chronic. Okay. Now, quickly, then the eczema, what is the diagnosis? History is very clear. So it's due to hair dye. Angathar eczema in the paraya. It is exogenous, more specifically in the dermatitis. Good. It's called contact dermatitis. And just remember that you've got allergic contact dermatitis and irritant contact dermatitis. The primary difference being that allergic contact dermatitis is secondary to sensitization, which means there is an immunological thing going on over there. While irritant contact dermatitis, it is like direct skin damage. എന്താ പറയുക നമ്മുടെ സ്കിന്നിൽ ഇപ്പോൾ എന്തെങ്കിലും മറ്റേ ആസിഡോ ആൽക്കലിയൊക്കെ വീണ് ഒരു ഇറിറ്റേഷൻ മാതിരി വരുമ്പോൾ ദാറ്റ്സ് ഇറിറ്റന്റ് കോൺടാക്ട് ഡെർമറ്റൈറ്റിസ്. വൈൽ ഇഫ് there is immunological sensitization because of the particular chemical or material, we call it allergic contact dermatitis. Okay. So irritant, direct skin damage, no immunology. Allergic contact, there is an immunological phenomenon. This is irritant dermatitis due to cement. This is allergic contact dermatitis due to footwear. What test will you use over here? So your diagnosis is allergic contact dermatitis. You want to confirm what is causing it. So which test would you use? You're given a choice of doing a single test, and the aim of the test is to find out what is causing the allergy. Yeah, Ig might show an elevated value, but then that may not really find out what is causing the allergy. Unless, of course, you're thinking of specific Ig, yes, but then that is mainly for type 1 sensitivity. Here, it's type 4 delayed sensitivity. So, ഇവിടെ ചെയ്യുന്നത് is something called the patch test. Okay. Simple point, allergic contact dermatitis in the test is called patch testing. And the വ്യത്യാസം എന്ന് പറഞ്ഞാൽ, unlike prick testing and all, you put the patch for 48 hours and then you do the reading. It's a kind of delayed sensitivity. Okay. Treatment, avoidance of contact, plus general treatment according to the stage of eczema, like we discussed. Diagnosis, based on the distribution. Yeah, one possibility would be pellagra, good, but simpler thing, face, neck, forearm, you think of photodermatitis. Okay, so the most important thing would be avoiding sun exposure, sunscreens, plus again you treat according to the stage. Plus, one important thing is that remember that any patient with photodermatitis always rule out things like SLE. Okay, so especially you have female patient, photodermatitis, joint pains and all, do a screening ANA, anti-nuclear antibody. Okay, so patient coming with dandruff on the scalp and these lesions on the face, what do you call this dermatitis? Scaling erythema on the nasolabial area, the eyebrows, beard area, retroauricular area, chest, axilla, in the dermatitis scenario. All these sites are rich in sebaceous glands. So, which is why this kind of dermatitis is called what? Good. It's called seborrheic dermatitis. Okay. Seborrheic dermatitis is a peculiarity, although it is an eczema, it is triggered by a fungus. Okay. Which is why treatment of factor in you have to treat the eczema, but also add an antifungal. Okay. So commonly, mild cases, what we do is we add a topical steroid with antifungal. And this is atopic dermatitis. So very common in children. usually starts from early childhood with lesions on the face, the extensor aspects, and then gradually becomes more of flexural eczema. Can be associated with other atopic features like rhinitis, asthma, and all those things. Quickly, so the last set of questions, and then answer. Yep. So basically, it's an allergic contact dermatitis, and like we said, that the treatment, the investigation of choice for allergic contact dermatitis is the patch testing. Okay. Okay. Good. So atopic dermatitis, and the key pointers are that child, very itchy, oozing, scoriated lesions, and atopic dermatitis is a type 1 sensitivity. So, like we said, associations are asthma, rhinitis, and all those things. So, Ig levels are generally very high. Okay. So, here, atopic dermatitis. So, seborrheic dermatitis, we said, is good. It is classified under eczema, but it is associated with a fungus, Pittosporum or Malassezia, which is why treatment also needs to involve a antifungal. So, answer is Pittosporum. Okay. Now, this is a question which is asked before, but just to show you that when you talk of topical steroids, also remember that there are different potencies of topical steroids. Now, for the exam, just remember that the mildest topical steroid given is hydrocortisone, and the strongest one given is clobetasol. There are others, but for the exam, I'm just mentioning these two. Okay. So the answer over here is hydrocortisone. Hydrocortisone acetate is one of the mildest things, while clobetasol is one of the more potent ones. Okay. Patch test is done after. Uh, So the normally first reading is done after 48 hours. The second reading, some people do it after 72 hours, some people do it after 96 hours, but uh, usually the question comes as only 48 hours. So whenever you see 48 hours, click that as the answer. Okay. As a rule, patch testing initial reading is done after 2 days. Okay, most important histological feature of eczema. So we said that eczema, if you take a biopsy, you'll find that empty spaces which are due to fluid. Looks like a sponge. Good. So that is spongiosis. And a spongiosis കൂടുമ്പോൾ ഫ്ലൂയിഡ് പുറത്തോട്ട് വരുന്നതാണ് നമ്മൾ ഈ ഊസിങ് ക്രസ്റ്റിംഗ് ആയിട്ട് വരുന്നത്. Irritant contact dermatitis is the most common thing which is involved is solvents. Okay, so acid bases and solvents. While for allergic contact dermatitis, the most common is metals, especially nickel. Okay, കുറേ സാധനങ്ങളുണ്ട്, but the most common cause for allergic contact dermatitis is nickel dermatitis. Last question. Okay, so even if it's 60 to 80, I would be happy. Okay, right. So thank you so much, and I'll just put in my email over here. So, and then in doubt endingly, you can just put me a mail and try to clear it. Okay. Any major doubts so far? Anything which you want to clarify? We are a bit out of time, but still. Okay, so I think വേറെ ഡൗട്ട് ഒന്നും ഇല്ലെങ്കിൽ I think we can stop. സ്വപ്ന അവിടെ ഉണ്ടോ? അല്ല കഴിഞ്ഞ് ജസ്റ്റ് ലോഗൗട്ട് ചെയ്യട്ടെ. ഓക്കെ.